This is the presentation for medical students by Dr. Mumtaz Ahmed Umar, and the topic of discussion is disorders of esophagus. Esophagus is a fibromuscular tube which connects the pharynx to the stomach. It is about 25 cm in length in an adult. It begins at the level of the inferior constrictor, which is the C6, or at cricopharyngeus. It is also the area of the upper esophageal sphincter towards the cardiac end, where there is a lower esophageal sphincter. The lower esophageal sphincter is a thickened circular smooth muscle and lies 40 cm from the central incisors, upper central incisors. There are some normal constrictions in the esophagus. The first is at the pharyngoesophageal junction at C6 level, which is 15 cm from the upper incisors. Then the second one at 25 cm, where there is crossing of the arch of aorta and the left main bronchus. And third, when it pierces the diaphragm, which is 40 cm from the central incisors. The importance of these constrictions is that sometimes the foreign bodies get lodged up at these sphincters. Now coming to the diseases of the esophagus, the first is the acute esophagitis. It is an acute inflammation of the esophagus which can be due to ingestion of the hot liquids, ingestion of caustic or corrosive agents, or laceration due to a swallowed foreign body, maybe after trauma by esophagoscopy, or by the monoleal infection of esophagus from the thrush in the oral cavity. And sometimes systemic disorders like pemphigus can also lead to acute esophagitis. Patients, they usually complain of dysphagia, retrosternal burning, or hematemesis. Diagnosis can be made from history, X-rays, and esophagoscopy. Another one, this is very important, the perforation of esophagus. Mainly it is caused by the instrumental trauma but can occur spontaneously. Instrumentally, it can be followed by esophagoscopy during the dilation of strictures with bougies, and the common site of rupture is just above the upper sphincter. While in spontaneous rupture, it usually follows by vigorous vomiting and involves the lower third of esophagus. Post-emetic rupture of all layers of the esophagus is called Boerhaave syndrome. Sign and symptoms. For the cervical rupture, there can be two types, either a cervical esophageal rupture or thoracic esophageal rupture. In cervical esophageal rupture, there will be pain, fever, difficulty to swallow, and local tenderness, and there will be signs of surgical emphysema in the neck. While in thoracic esophageal rupture, the pain is there and it is referred to the interscapular region. The patient will complain of fever, high grade fever from 102 to 104 degrees centigrade, and there will be signs of shock along with surgical emphysema in the neck, and crunching sound over the heart is known as Hammond's signs, which is positive in thoracic rupture, and patient may also present with pneumothorax. Investigations include the blood CBCs, X-rays of the chest, neck and chest. They may show whitening of the mediastinum, surgical emphysema, pneumothorax, pleural effusion or gas under the diaphragm. Fatal complication from perforation, which is mediastinitis, can occur. Now, how to diagnose? Diagnosis is usually clinical. In these cases, barium swallow is usually avoided, as if there is perforation, barium will leak into the mediastinum and can cause mediastinitis. If one has to do the any investigation, then gastrographin instead of barium swallow is used. Barium is used. Gastrographin is used instead of barium. In treatment, first of all type of food should be stopped. All oral feeds are stopped immediately, and nutrition is maintained through IV route. Large doses of intravenous antibiotics are given. In early cases of perforation of cervical esophagus, it can be managed conservatively, and only treatment if required is drainage when there is suppression. The retrovisceral space or upper mediastinum can be drained through the neck. In cases of thoracic rupture of esophagus, it is a more serious complication. It is a more serious perforation than the cervical one, and it is only managed surgically if the diagnosis is made early within the first 6 hours of the perforation. However, if it is not diagnosed early, and then surgery is only restricted to drainage of the infected area. Corrosive burns of esophagus. Corrosives can be acids, alkalis, or any other chemicals which can be swallowed either accidentally in children or taken with the purpose of suicide in adults. Pathology, there will be severity. The severity of esophageal burns depends on the nature of corrosive substance, its quantity and concentration, along with the duration of its contact with the esophageal wall. Alkalis are more destructive because they penetrate deep into the layers of the esophagus, and secondly because they are odorless and tasteless as compared to acids. Esophageal burns run through 3 stages. First, there will be the stage of acute necrosis. Then there will be the stage of granulations. In this, the slough it separates, leaving the granulating ulcer. Then the stage of stricture. Stricture formation begins at 2 weeks and continues for 2 months or longer. To evaluate the patient, it is important to determine the type of caustic ingested. There may be signs and symptoms of the shock. Patient may have upper airway obstruction. The patient may present with mediastinitis or peritonitis, or there may be acid-base imbalance. Have to check the face, lips, and oral cavity for associated burns. Then to diagnose, X-rays of the chest and soft tissue of the lateral view of neck can be done. In management, first of all, patient needs to be hospitalized. We have to treat the shock and acid-base imbalance by intravenous fluids and electrolytes. Also have to monitor the urine output to check for renal failure. Pain has to be relieved immediately. Then airway obstruction which can be developed has to be relieved. For such cases, tracheostomy may be needed. Neutralization of the corrosive by appropriate weak acid or alkali given by mouth can be done, but only effective if done within first 6 hours. But still, it is controversial whether it helps the patient or no. Parenteral antibiotics should be started immediately and continued for 3 to 6 weeks depending upon the degree of burns. Then steroids should be started within 48 to 96 hours and continued for 4 to 6 weeks to prevent the stricture formation. Again, passing of the nasogastric tube is controversial, as if the burns are severe and you pass the NG tube forcefully, then it can cause perforation, but it is useful to feed the patient and to maintain the esophageal lumen if done easily. Esophagoscopy, again, it is controversial. Some suggest it should be carried out immediately and others don't favor it, but it should be done to see the degree of burns and to plan further treatment. But esophagoscope should not be passed beyond the first sphere circumferential burn. Follow the patient with esophagogram and esophagoscopy for the development of any stricture. However, if stricture develops, then it can be treated by esophagoscopy and prograde dilatations, gastrostomy and retrograde dilatation, esophageal reconstruction or bypass if dilatations are impossible, if longer segment of the esophagus is involved. Patients of corrosive injuries of esophagus usually requires lifelong follow-up. Benign strictures of esophagus. They occur when the muscular coat of the esophagus is damaged. The most common causes are burns due to corrosive substances or hot fluids, trauma to esophageal wall due to impacted foreign bodies or instrumentation or any external injuries, ulcerations due to reflux esophagitis, ulcerations due to diphtheria or typhoid, sites of surgical anastomosis or congenital, usually in the lower third. Clinical features: the patient will present with dysphagia, first to solids and then to liquids. Then when the obstruction is complete, there will be regurgitation and cough. Patient is usually malnourished. And diagnosis is made on barium swallow, and esophagoscopy is required to exclude malignancy, either flexible esophagoscopy or rigid esophagoscopy. Treatment: there are 2-3 treatments. Prograde dilatation with bougies. It should be done under direct vision through the esophagoscope, and dilatations may be required frequently. Then gastrostomy may be done. Helps to feed the patients and give rest to the inflamed area above the strictures. When inflammation subsides, prograde dilatation can be restored. Patient can be given a thread to swallow, which is recovered from the stomach, and prograde or retrograde bouginage can be done. Surgical excision of the stricture segment and reconstruction of the food passage using stomach, colon or jejunum can also be done. Hiatus hernia. It is the displacement of stomach into the chest through esophageal opening of the diaphragm. Most patients are elderly, past 40 years. This disorder is of two types, sliding and paraesophageal. In sliding hiatal hernia, stomach is pushed into the thorax in line with the esophagus. Reflux esophagitis is a common symptom and may give rise to ulceration and stenosis because the cardioesophageal junction is pushed up. That's why reflux esophagitis is the main symptom, which is not present in paraesophageal. In this, the part of stomach along with its peritoneal covering passes up into the thorax by the side of esophagus, and the main symptom is dyspnea on exertion. Because the gastroesophageal junction still remains below the diaphragm and the angle between the esophagus and stomach is maintained, so reflux esophagitis is not usually present in this type of hernia. Diagnosis is based on barium swallow and X-ray chest. Treatment is mainly surgical. The hernia is reduced and diaphragmatic opening repaired. Early cases and those unfit for surgery can be treated conservatively to reduce the reflux esophagitis by measures such as sleeping with head and chest raised, avoidance of smoking, use of drugs that reduce the acidity like antacids and proton pump inhibitors, reduction of obesity, and attention to the causes which raises the intra-abdominal pressure, for example chronic constipation, chronic cough, so those should be avoided or treated. Globus pharyngeus or globus hystericus. It is a functional disorder where the patient complains of feeling of a lump in the throat, and this feeling, because there is no true dysphagia, and this feeling is more between the meals rather than during the meals. The clinical examination of the pharynx, larynx and base of tongue is normal. Treatment is basically limited only to reassurance when there is no obvious cause has been found, and psychiatric evaluation may be needed in some patients. Motility disorders. The motility disorders can be hypermotility or hypomotility. In hypermotility disorders, there is cricopharyngeal spasm, diffuse esophageal spasm, nutcracker esophagus, and hypomotility disorders are cardiac achalasia, gastroesophageal reflux, scleroderma, amyotrophic lateral sclerosis. It may involve the upper sphincter, lower sphincter, or body of esophagus. Cricopharyngeal spasm. It is caused by the failure of upper esophageal sphincter to relax properly. There is incoordination between the relaxation of the upper esophageal sphincter and simultaneous contraction of the pharynx. The common causes are cerebrovascular accidents, Parkinson's disease, bulbar polio, multiple sclerosis, and muscular dystrophies. In diffuse esophageal spasm, it is characterized by strong non-peristaltic contractions of the body of esophagus, while sphincteric relaxation is normal. The symptoms consist of dysphagia or odynophagia with substernal chest pain, simulating angina pectoris. Barium swallow may show segmental esophageal spasms, giving a rosary bead or a corkscrew type of esophagus, though it may be normal in some. So this is the picture showing the rosary bead or corkscrew type of esophagus. Cardiac achalasia. It is a primary esophageal motility disorder which is characterized by absence of peristalsis in the body of esophagus and insufficient relaxation of lower esophageal sphincter with high resting pressure. There is loss of ganglion in the mesenteric plexus, which is present in the walls of the esophagus, and there is selective loss of postganglionic inhibitory neurons, which contains both the nitric oxide and vasoactive intestinal polypeptide. The main symptom is dysphagia, but now it is more to liquids than solids, which is reverse in stricture and in cancers. There may be regurgitation of swallowed food in the night, and patient may also present with chest pain. Diagnosis is mainly based on barium swallow. The barium swallow will show a dilated esophagus with narrowed lower end, which is also known as a rat tail appearance or a bird beak appearance. Manometric studies showed low pressure in the body of esophagus and high pressure in lower esophageal sphincter and failure of the sphincter to relax. Endoscopy can be carried out to exclude a benign stricture or a development of cancer. Treatment of choice in cardiac achalasia is modified Heller's operation, in which myotomy of narrowed lower portion of esophagus is carried out. Myotomy is cutting up of the layer of muscle coat. Or forceful pneumatic dilatation of lower esophagus can also be carried out in those patients who refuse the surgery or are unfit for surgery, but there is chance of perforation in this case. Gastroesophageal reflux disease. It is due to the decreased function of lower esophageal sphincter, thus permitting the regurgitation of gastric contents into the esophagus. The symptoms consist of the substernal pain, heartburn, and regurgitation. Treatment is elevation of the head of bed at night, avoiding food at least 2 to 3 hours before bedtime. Medicines include antacids, then the drugs which increase the tone of lower esophageal sphincters like metoclopramide, H2 receptor antagonists like cimetidine and famotidine, proton pump inhibitors like omeprazole, esomeprazole, lansoprazole, pantoprazole. They are more commonly prescribed than the H2 receptors. Then patient should be advised to avoid smoking, alcohol, caffeine, chocolates, mints, and carbonated drinks, along with avoidance of stress. Then surgical treatment includes the anti-reflux surgery, which is Nissen fundoplication. Complications: it can affect not only the esophagus but the larynx and pharynx, even the nose and ear as well. So in esophagus, it can give rise to esophagitis, benign esophageal strictures, Barrett's esophagus. In lungs, can lead to aspiration pneumonia, asthma, or chronic cough. In larynx, it will lead to posterior laryngitis, again chronic cough, irritation in the throat, ulcers, and even can give rise to cancer. In ear, it can give rise to otitis media, and miscellaneously it can cause Globus hystericus. Neoplasms of Oesophagus. Benign neoplasms, it can be leiomyoma, which arises from the smooth muscle and grows in the walls of esophagus. Others can be mucosal polyps, lipomas, fibromas, and hemangiomas, and other benign tumors. They are often pedunculated and present in the esophageal lumen. Endoscopic removal is avoided because of danger of esophageal perforation. However, treatment is surgical excision. Carcinoma of esophagus. Smoking and alcohol consumption are high risk factors. About 5% of esophageal cancers arises in the pre-existing pathological lesions such as benign strictures, hiatus hernia, cardiac achalasia, and diverticula. Plummer-Vinson syndrome is another predisposing factor. 93% cases are squamous cell, while only 3% are adenocarcinoma. Spread of carcinoma is either direct, by lymphatic drainage, or blood-borne. Clinical features include dysphagia, which is the early symptom, along with the substernal discomfort. Dysphagia can be progressive, leading to emaciation of the patient. Patient may also complain of pain, which is referred to the back, and may have aspiration problems. Diagnosis is done on basis of barium swallow, esophagoscopy with biopsy, and histopathologically diagnosing that, and CT scan of the neck, chest with or without abdomen. Treatment. Radiotherapy is the treatment of choice. Surgery is preferred for the cancers of the lower one-third. The affected segment with the wide margin of esophagus proximally and the fundus of stomach distally can be excised with primary reconstruction of the food channel. In advanced lesions, only palliation is possible. An alternative food channel can be provided by a bypass operation, esophageal intubation, or permanent gastrostomy.